Hello, everyone. Thank you for coming. Welcome to NAUTO's 39th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth, where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAUTO's Executive Director. Norm, the stage is yours.
Thank you. It's wonderful to be here with everyone. We're excited to have you with us for our 39th annual conference. This year's theme is Telling the Story, Strategies for Improving Healthcare Data. This will be our first of 2 Igniter sessions. This one is titled Pathways to Addressing SUD Data Gaps, State Lessons Learned. Today's moderator is Emily Sim from Comagine Health. Let's welcome Emily to the stage.
Hello, welcome to the first session of the Igniter series for this year's conference. And I am Emily Sim. I'm the Senior Director of Analytics at Comagine Health, and we are a national nonprofit healthcare consulting firm, and we work collaboratively with community partners to improve healthcare. And I'm excited to get to introduce our speakers today. And you're going to hear 2 presentations, and I would ask that as you listen to these 2 sets of speakers, please type your questions for them into the chat as we go. And then we will hold a Q&A until the end after we hear both presentations. So type in your questions as we go. Now, first, we will hear from Leah MacArthur and Robert MacLean from CHIA in Massachusetts. And they will be discussing their experience navigating 42 CFR Part 2 as a state all-payer claims database. Leah and Robert.
Hi everyone, my name is Leah, and I'm going to be presenting on 42 CFR Part 2 and the pathways for state APCDs to access, use, and disclose substance use disorder data. So just some quick facts about Part 2 and its legislative predecessors. We're going to go back in time about 25 years before the enactment of HIPAA to the 1970s, an era of paper records and limited care coordination. And the policy behind Part 2 and its predecessors was to encourage people to seek assistance for substance use disorders without fear that seeking assistance would lead to some kind of evidence in a proceeding against them. And the focus back then really was on data confidentiality exclusively. Under no circumstances could SUD records be disclosed. And the current status of Part 2 is that it remains highly restricted for sharing SUD data, but does allow for some exceptions. Now, to determine whether Part 2 is applicable, there are 2 sort of buckets we need to look at. One being the entity involved in generating or holding the data, and the other being the data itself. And keep in mind that Part 2 does not apply to all records involving substance use disorders. The law is limited in scope. However, many entities do erroneously apply Part 2 restrictions to all SUD data. So what do I mean when I say the entities? I'm referring to Part 2 programs and lawful holders. And a Part 2 program is a program that is federally assisted and holds itself out as providing SUD care. Now, there's a lot to unpack there, but basically a Part 2 program is either a standalone treatment facility or a specialized unit within a larger medical facility that receives some kind of financial assistance from the federal government, for example, participating in Medicare or Medicaid, or receiving tax-exempt status from the IRS, and holds itself out as providing SUD care. Now, this third bullet is a little squishy. It's not specifically defined within Part 2. However, SAMHSA has provided guidance indicating basically you know it when you see it. So advertising that you provide SUD care, providing consulting services related to SUD care, or receiving authorization to provide SUD care are all indicative that an entity holds itself out as providing SUD care. So some examples of non-Part 2 programs would be primary care physicians, out-of-pocket SUD facilities, and payers. The other entity involved is a lawful holder, which is a person or entity bound by Part 2 who receives SUD records either because of written consent with notice of disclosure or pursuant to an exception to the written consent requirements. We're going to do a deeper dive into this in a bit, but you can basically think of lawful holders as downstream recipients of SUD data from Part 2 programs or other lawful holders, either with consent or pursuant to a consent exception. And some examples of lawful holders that come up often would be contractors, payers, primary care physicians, and APCDs. Now, APCDs are unlikely to obtain SUD data pursuant to consent. This is usually related to treatment, payment, and care coordination purposes. Where APCDs are going to want to look to are the exceptions to consent, which I've listed here. We have medical emergencies, court orders, scientific research, audit and evaluation, and public health authority. And these final three are most likely to apply to APCDs. So just an illustration of how SUD data is shared, we see that a Part 2 program, in this case an addiction provider, receives consent for treatment purposes to disclose the data to a patient's primary care physician. The PCP then becomes a lawful holder and is able to provide the data pursuant to that consent to its contractor, who also becomes a lawful holder. Now, that second trajectory there, we see that the Part 2 program receives consent to disclose the data to a patient's payer or insurer for payment purposes. The payer can then disclose the data to an APCD pursuant to a consent exception, in this case, a research purpose. The APCD then becomes a lawful holder because it's received the data pursuant to a consent exception. So I talked earlier about those two buckets, the entities and the data. So when is SUD data subject to Part 2? Now, when I talk about SUD data, I'm talking about any information, recorded or not, created, received, or acquired by a Part 2 program relating to a patient and including patient identifying information. Now, this last part here is very important. Only SUD records containing patient identifying information are subject to Part 2 protections. And that means SUD data that's been de-identified under HIPAA is not subject to Part 2 and can be disclosed by any entity without violating Part 2. So now we're going to get into the meat of the presentation, how APCDs can obtain and use SUD data and who can get SUD data from APCDs. So I touched on the research exception earlier. APCDs may obtain identifiable SUD data under the research exception if it can meet the requirements set forth in Section 252. Now, there are a number of requirements there. Basically, you're going to want to see if an entity is subject to the common rule or falls within an exception to the common rule. APCDs who obtain the SUD data pursuant to the research exception can disclose identifiable SUD data then to external researchers who also meet the 252 requirements. And so we can see the trajectory here. A Part 2 program receives consent for payment purposes and discloses the data to a patient's payer. The payer, then pursuant to the research exception, discloses the data to an APCD who becomes a lawful holder. The APCD can then disclose identifiable or de-identified data to an external researcher for research purposes as well. The public health exception is different. Here we see APCDs may obtain de-identified SUD data under the public health exception if it can meet the requirements set forth in 254. Again, there are a number of requirements there. I encourage everyone to take a look at that section. APCDs may then disclose de-identified SUD data to external researchers if it receives the data pursuant to the public health exception. Now, this may seem redundant because we spoke earlier about how de-identified SUD data or SUD data that does not include patient identifying information is not subject to Part 2. However, it is in here just providing additional assurance that de-identified SUD data can be shared for this purpose. And so we can see the trajectory here, and we want to focus on that third arrow in X. We see that an APCD that receives the data pursuant to the 254 public health exception may not disclose identifiable SUD data to researchers, only de-identified, which makes sense because it only received the de-identified SUD data under this exception. The audit and evaluation exception is also different. We see here APCDs may obtain identifiable SUD data under the mandated by statute or regulation subsection of the audit and evaluation exception. So for an example, an APCD has legal authority to examine care and outcomes at Part 2 programs. It can obtain identifiable SUD data pursuant to this exception. However, it cannot redisclose identifiable SUD data. It can only redisclose identifiable SUD data back to the originating entity. It may disclose de-identified SUD data. And so again, we're going to want to look here at that third arrow and X. We see that an APCD who receives identifiable SUD data pursuant to the audit and evaluation exception may not then disclose that identifiable SUD data to external researchers. It may only disclose de-identified SUD data. And so in general, there are two pathways for APCDs to obtain SUD data. The first is to determine that the SUD data is not subject to Part 2, either because the SUD data did not originate from a Part 2 entity or because the data has been de-identified pursuant to HIPAA. The second pathway is when the SUD data is subject to Part 2, and there we're going to want to look at the exceptions to consent, namely the scientific research exception, the public health authority exception, and the audit and evaluation exception. And if you have any additional questions, if you're interested in learning more, please feel free to email me at leah.macarthur@gms.gov or visit our website at www.gms.gov. Thank you.
Thank you, Leah and Robert. And now we will hear from Gina Robertson from Onpoint Health Data, and she will be sharing about navigating substance use disorder data availability in APCDs.
Good afternoon, folks. My name is Gina Robertson, and I work in analytics here at Onpoint Health Data. My team focuses on validating the quality and completeness of data found in all payer claims databases, or APCDs, so that downstream APCD end users have a good understanding of the data available to them for their healthcare studies. Today, I'll be talking with you about how to understand and navigate the availability of substance use disorder, or SUD data, in your APCD. Understanding data availability for any study is important to critically assess the strength of your study's methods and its outcomes. All studies are going to have some limitations. What's important is that you are aware of your data limitations, don't beware or avoid them, so that you can recognize where changing methods for your study may be necessary or where caveats of your downstream study outcomes may be important to detail. Understanding SUD data availability specifically is important, as there's a widespread notion that SUD data in APCDs is largely redacted due to payer interpretations of 42 CFR Part 2, which Leah just did a great job detailing. As SUD diagnostic rates continue to rapidly increase across the country, there's been a call to understand if and how APCD data can be used as a tool for analyzing SUD access and quality of care to improve treatment for these patients. And so to support our clients interested in pursuing these studies, Onpoint performed a quality and completeness evaluation last spring to assess SUD data availability rates in each of the APCDs that we work with, so that our clients had some guidance as to what types of SUD data were available to them in their existing databases. The first question that we wanted to answer in our quality evaluation was, how do we identify what data is absent? If a submitter is withholding SUD data, how will we know? We knew submitters took a variety of approaches to redacting SUD data, and those approaches involved using different data elements in the APCD to identify SUD data within their submissions for redaction. So to find missingness, we chose to canvass one of these fields holding SUD-specific service codes for its completeness of SUD data. We evaluated the list of fields shown here where SUD data can often be found, and we determined that for our study, using the ICD diagnosis code would be the best mechanism for evaluating who was sending SUD services and who wasn't. Out of the fields listed here, we knew the ICD diagnosis code to be most consistently reported on all medical claims. We also knew that medical claims were where SUD-specific procedures or provider specialties were reported. A SUD-specific diagnosis code could almost always be found to log medical necessity of the service. In that way, the diagnosis code felt most encapsulating to assess SUD data availability than the other fields that we explored. Feedback from health plans also confirmed this approach. In conversations we had with payers that redacted SUD data, many relayed their redaction method involved removing all medical claim lines from their submissions that reported a SUD diagnosis code. And so when measuring SUD data availability, there were a couple key questions that we wanted to answer. First, who was redacting SUD data and how? And second, what impact did SUD data redaction have on overall SUD data availability? To answer these questions, we started by compiling data from past surveys conducted with health plans on their approach to SUD data redaction. These surveys gave us a good idea of who we knew to be reporting SUD data to the APCDs so that we could generate some general rates of SUD data volume from the submitters that were including SUD data within their files. These rates served as our benchmarks for assessing a submitter's SUD data availability, which we stratified by product type, meaning commercial, Medicaid, or Medicare, because we knew the volume of SUD data to vary across these markets. We then calculated the percent of total medical claim service lines per submitter per product, reporting a SUD principal diagnosis code as defined by the Substance Abuse and Mental Health Services Administration, or SAMHSA, because submitters often referred to SAMHSA's SUD diagnosis code sets as their reference for SUD data redaction. And finally, after benchmarking these achieved percentages of SUD data availability, we assessed how submitters redacting SUD data impacted their overall SUD data availability across the APCD. So here's a sample of our results. These are real results from our data quality evaluation. We received permission from a few select clients to display these today for purpose of discussion. Just to orient you folks to the visuals we're seeing here, in the left-hand corner, you can see we're reviewing only commercial product type results with payer names redacted from the visual. Each row of data represents a commercial payer's percentage of total medical claim service lines incurred in 2022 that report a SUD diagnosis code as its principal diagnosis. And in the right-hand column, you can see bars that resemble the volume of total medical claim lines, both SUD and non-SUD, submitted by each payer to show the payer's makeup of the overall commercial market. You'll notice the actual number of total medical claim lines reported by each payer is also redacted here to protect submitter and client privacy. So here you'll notice a few things. The submitters in blue are the submitters who reached our team's commercial benchmarks for determining SUD data to be available. And the submitters in red are those who achieved much smaller rates of SUD data that suggested redaction. Those benchmarks I mentioned here are also outlined on this slide and show the general rates per product type by which we assessed a submitter's SUD data availability. This client had most of its commercial submitters reporting SUD diagnoses at a rate we have determined to signify available SUD data, so that's great. But you'll notice that the 3 commercial submitters with the largest volume of claims are also the 3 that are redacting SUD data from their medical claims, which means the state as a whole has very low rates of overall SUD data availability for their commercial market. In reviewing SUD data availability across states, we noticed a wide variation in overall commercial data availability per state. So here you can see 5 de-identified APCDs with SUD data availability in the commercial market ranging from 19.5% to nearly 100% available SUD data. This percentage represents a proportion of commercial medical claim lines submitted by commercial payers who met our SUD data availability benchmarks. You could see in the previous slide we reviewed is represented by state 1 here, where submitters who make up the largest volume of commercial market are redacting SUD services from their data and thereby bringing the overall commercial market SUD data availability rate down to 19.5%. In contrast, state 5 had even its largest payers including SUD services, while only a few very, very small payers were redacting SUD data and represented very little impact to the overall SUD data availability in this APCD. And the final finding we wanted to illustrate today is that even within submitters redacting SUD data, there was variation within their approach for redaction. We identified that often payers redacting SUD data did so based on categories of diagnosis, and that not all submitters use the same categories to redact their submissions. So here you can see a couple examples where submitter number 1 redacted all but nicotine diags, while submitter number 2 redacted all but alcohol diags from their medical data. This finding is important because it introduces the concept that submitters who redact SUD data from their medical files can still be incorporated into certain SUD diagnosis-specific studies. Even within redacted data sets, there's still the possibility that subsets of the data submitted are valuable, depending on your study and its required data set. So just to wrap things up with a few key points. First, although SUD data has been widely viewed as excluded from APCDs, you may be more like a state 5 and have more SUD data than you think. Second, assessing data availability for any study proposed is critical to understanding the strength and outcomes of your study. And finally, APCDs with incomplete or less available SUD data are typically driven by payers with large markets who are excluding SUD data. So what can you do if your APCD is challenged by SUD data incompleteness? You can engage submitters in their ability to provide more complete SUD data, talk with them about their challenges in providing this data set, and hear their concerns to explore what options may work best for your APCD. You can focus on studies that do have SUD data available from your APCD. Understanding what SUD data is available can help steer teams to focus on studies that can be answered by the data you have in-house. And finally, you can explore supplementing APCD data with other data sets, like gaining access to clinical data or using aggregate and de-identified SUD data sets that may help to supplement the gaps your APCD cannot fill. Understanding your APCD's data availability is the first step to paving the way with enhancing SUD treatment for all. And I hope this presentation helps get the wheels rolling in your state to pursue a similar data availability exercise. Thanks so much.
Great, thank you so much. Okay, I am getting some background noise, Charles. Can you hear that? Okay, thanks. Thank you, Leah, Robert, and Gina. And let's look at the audience chat. And we have one question in the audience chat, so I would love it for the rest of you that I know are on here and listening, if you could start typing in some more questions to ask these folks about what we've just heard about. But let's start with the question from Valerie Garrison. Can you put that one on for us, Charles? Great. And Valerie asked, to perhaps oversimplify the first presentation, am I correct in understanding that as long as we have SUD data available to us in our APCD, then we are able to report aggregated SUD statistics and or send de-identified data to clients, partners as needed? Look to Leah and Robert to answer that one.
Hi, so I'm sorry if there's background noise here. I'm not sure what's going on with my audio, but I'll answer this as best I can. So some of this, there's a lot of nuance here, and again with the caveat that this does not constitute any legal advice, but in terms of de-identified data, it doesn't necessarily mean you're going to violate like part 2 if you send aggregated SUD statistics. I would really suggest looking at like your state's statutes and regs when it comes to disclosing data, because that may be where there's a lot of nuance and where you're going to want to look. But like in general, the de-identified SUD data doesn't need to necessarily fit into those consent exceptions in order to be disclosed. Robert, if you have anything to add, please keep me honest here.
No, Leah, you're correct. I think the important lesson you can take away from Leah's presentation is understanding the source of the data, who they are they actually subject to part 2? And then what is the data that they're holding? Is it actually identifiable SUD? And if both of those questions are yes, then it's having enough confidence in your understanding of the exceptions to Part 2 and whether or not your state agency can meet or fit into those exceptions. For example, would you be able to request from a payer under the research exception, or do you have legal authority to do an evaluation of Part 2 programs, or do you even have public health authority? And then so those are tools that APCDs can leverage. Again, if you're asking for SUD from a Part 2 provider or lawful holder. And the goal of our presentation was to really address gaps that you may find in the data so that you can engage the submitters, and that's where it sort of complements Gina's presentation nicely. Hope that helps.
And I have a follow-up question for you, Robert, on that. So, I mean, I haven't looked at those 2.52, 2.54. You're talking about these different requirements to meet so that you can have the exception. How hard are those requirements to meet? Like, how are you seeing how hard they are to meet? Are they?
Yeah, I think that all depends on the nature of the relationship that you have with the data submitter. I think typically it's best to always document that type of authority with either a DUA or a letter agreement, just to memorialize what the APCD is representing in terms of its authority to meet one of those exceptions to get the SUD data.
Thank you. And then let's look at Natalie's question. Charles, if you could pull that one up. And Natalie asked, and I think that this is probably, we'll have Gina take the first stab at this one. What list of SUD primary diagnosis codes do you use to identify SUD data?
Yeah, thanks, Natalie. So SAMHSA publishes a standard list of codes that they recognize as SUD diagnosis codes. Those are available online. And I think within the NAUTO conference platform, you can shoot me a message if you can't find them, and I'm happy to send over a link for those codes as well, and also make these slides available to folks who would like them.
Thank you. And as a reminder for those in the audience, please type in questions that you have. I had a question that I can ask while we're waiting to get more questions from the audience, unless I missed a question. Oh, here's another question that we'll go to before we go to mine. So this question is, nice presentations, thank you. Any idea which states are already collecting SUD data? I'll just leave that out to any of you.
I think we can certainly respond to CHIA's situation, and we do collect SUD at CHIA, and its availability is sort of dependent on the requester and their authority. So to answer the question specific to CHIA, yes. For other states, we can't speak to that, but maybe Gina might know as a result of her work.
Yeah, I think I'll mention, probably as a way to protect our clients' privacy, I probably can't list any specific states, but I'll say that largely payers across the country will use the same redaction methods across different state APCDs. And in other words, meaning for the folks that are not redacting their data, they're not redacting across many different APCDs. So I would say within each APCD, there is a level of SUD data available. And I think the goal is to understand what level of availability you have in yours. So doing a type of quality evaluation where you can assess who is sending it and how much, and are they redacting any specific diagnostic categories? Because I would say, by and large, most states have some level of SUD data available in their APCDs.
And I had a follow-up question on that one, Gina. This is a question that I wrote down while you were speaking in your presentation. But from the different states that you've looked at, what are you noticing that is driving the availability of SUD data in different states? Like, why is there so much variation?
Yeah, I think mainly it has to do with the market size of the payers that are redacting it in that given state. So I would say, again, by and large, we're seeing the same payers redacting using some conservative methods for data redaction. So redacting all or almost all SUD diagnostic categories. And if your state is one of those states that has one of those payers who are redacting their data in a large market volume, that means you're going to be more impacted by that payer's redaction size. And so I think for the most part, it's specific health plans that are redacting data using like an overreaching redaction method, and how present are those payers within your own APCD.
Great. That brings up another question that I will come back to after we go to this question from Alice. So could you put Alice's question up, Charles? Thank you. So for the purposes of identifying and excluding SUD data from claim submissions to APCDs, is the claim exclusion at the claim level or the line level that is attributed to a reported SUD diagnosis? And are you seeing claims exclusion where a SUD diagnosis is the primary diagnosis or secondary, tertiary, et cetera?
Good question, and I'll actually answer your first, if that's okay. So we did look to see if there were differences in redaction methodology by secondary diagnosis compared to primary diagnosis. For the most part, what we were seeing is that if payers were redacting data in their primary diagnosis field, they were applying those same redaction methods to their secondary diagnoses as well. However, if you think about the use of your data, just note that obviously you would want to encompass as many secondary diagnoses within like a SUD study to capture all SUD claims available to you. So this method of using the principal was really just a method for us to canvass those fields, but the same redaction methods were applied across the diagnosis fields. And then your first question related to the claim exclusion or the line level. So we took a look at service lines, although I believe those would be repeated across the different service lines. So they're reported at the claim level, but we were examining service lines.
Thank you, Gina. And here is another question for Gina from Sylvia. Do you know to which extent specific states are maximizing the innovative use of APCD SUD data to inform policy decisions, resource allocation, or program effectiveness in substance use treatment and prevention?
Yeah, good question. I do know that specific state APCDs or just states in general are obviously releasing a lot of important SUD studies right now that are supported by some APCD data. But I would say, again, because the APCD has some limitations, those gaps are filled by other supplemental data resources as well. So I think I can't list any specific cases, and I'll have to follow up with you, Sylvia, if I can think of a study where APCD data is directly impacting that. But hopefully as states learn more about their availability and the level of completeness that they have, this would become a bigger tool for states to use those claims data resources as a method of supplementing the other data sources that they do have available to them. Robert and Leah, with Chia, I don't know if you folks have any specific studies you can think of too from your end.
Yeah, Chia does partner with other state agencies, I think most notably our Department of Public Health, in facilitating a large research and policy project that stem from the opioid crisis. So we are partnering with them, and they do have very specific legal authority that made this project feasible for both Chia and DPH.
I know the state of Vermont too does a ton of really amazing opioid use studies as well. So there's a lot of different use cases out there that are supported by APCD data that I think you could take a look at if you're trying to brainstorm ideas.
I have a question for Robert and Leah. So as we were listening to your presentation, you were talking about this common misconception maybe that, SUD data isn't available when it is. Um, how much do you think of the lack of using SUD data from APCDs is because of a misconception versus maybe the completeness or the usability or the being able to qualify for an exception? Can you speak to that a little bit?
Sure, I'll provide a quick assessment and then Leah can provide more context. So I think what we were speaking to was, I think, our experience in, I think, a lot of entities interpreting Part 2 broader than it should be and saying that their data was subject to Part 2 and therefore they couldn't disclose unless a legal exception was met, or maybe they weren't even aware of the legal exception. Just a lot of entities appear to take just the simple route and just saying, we have SUD and we won't disclose it. And then what we were looking to do was empower this audience to know that when they face that, statement, they can ask, well, why is your data subject to Part 2? Are you a Part 2 program? No. Are you a lawful holder? No. Then I think we can do this without confronting Part 2, and you can just make this like a normal healthcare disclosure. I think that's the first avenue. And then if they are subject to Part 2, informing them that there are exceptions, that state agencies and researchers and public health authorities are allowed to get the data. I think what we were looking to do is sort of shine more light and knowledge for APCD users to access and get the data. But yeah, Leah, if you wanted to share your thoughts as well, I'd welcome that.
Sure. I think also, so Part 2 has really evolved not just from, the sort of early stages in the 70s, but within the last 5 years, maybe, especially since like 2017, there have sort of been expansions with some of the exceptions, notably the public health exception, which I talked about, but also with the research exception, it's sort of been expanded. And we sort of put a note in the presentation. I think if folks want to visit the Federal Register and take a look, not just at the reg itself, but at the comments and responses that SAMHSA has provided, because that both gives some context into the changes and the expansions that people may not necessarily be aware of. So in addition to maybe just lumping all SUD together, whether it's been de-identified or whether it's identifiable, and just saying, oh, we can't share it, it's SUD, it'll violate Part 2, people also just may not be aware that there are these new avenues that they can take that exist now that maybe didn't exist 15 years ago, 10 years ago.
Great, thank you. Charles, do we have time for one more question, or not? Or do we need to wrap up? We do have time for one more question. Okay, I do have one last question, which is, so Gina, you had talked about, that if the difference is really just different payers and how they're interpreting what they need to, redact and what they don't. Is there work going on with these payers to try to help them have a different way of looking at it? And if so, what is that work?
Yeah, so I'll say a couple things about that. First, I'll say I'm not a lawyer, so I can't give legal advice, but I do know of states who are working with their legal departments to help understand whether they can or cannot try to encourage or compel submitters to send that data, and are reviewing, like Leah and Robert are talking about, the specs of 42 CFR Part 2 and understanding what their parameters are to encourage submitters to send that. I think the first step is getting that conversation with submitters going. So having the availability to have that feedback loop. What are the challenges that you're facing? And are there any ways that we can help brainstorm your team to be able to send that data or identify like which data is subject to Part 2 and or understand that you're able to send it as part of the research exception. So there's a lot of different ways that states are currently communicating with their payers to encourage that data submission. And I think the movement's going to continue to grow. So I encourage states to really team up and brainstorm tactics together, because I think, once one paves the way, we can all kind of get going. So it's all exciting stuff.
Great. Thank you so much. Thank you, Gina. Thank you, Leah. Thank you, Robert, for those presentations and the discussion that we've had today. And please join us next week. We will have another Igniter session, and that session will be Data Informing Care, and that will be organized and moderated by Sarah Halvick, also from Comagine Health, my colleague. Thank you, everyone, for joining us today.
Thanks all.